management of those patients has changed dramatically with the emergence of novel therapies, and so we had we basically have now a number of IO immunotherapy-based combination regimens have shown to be superior to target therapies, and they now became the gold standard. So the default plan for most of the patients who walk in the clinic with advanced renal cell carcinoma will be offered an immunotherapy-based combination. Now, before you think of that, there's a number of factors that play a role or important for you to decide who gets what, right? So, location of the disease, performance status, labs, is this a patient with newly diagnosed advanced disease or a patient who recurred? When did it recur? The number of sites of metastasis, those matter. Some of them are integrated into scores that come out of a multivariate analysis like IMDC score or Memorial Sloan Kettering. And we tend to group them into good, intermediate, and poor risk patients. And it is true that a lot of the data that came out of these phase 3 trials with checkpoint inhibition-based combinations, kind of show us data for these different groups, right? So, and those are groups that have been shown, or, they were originally shown to be prognostic. And this was in the TKI era. We do now use them, the way to select patients for these treatments. But they were originally developed with a prognostic value. So with that said, those factors are relevant. And really the debate is, when we think of who gets what, we're thinking, first of all, is this a patient who needs treatment? Because we do know that some patients, or a subset of patients, maybe 1 out of 10, are well managed with active surveillance. And they tend to be good risk patients, selected group of patients, not a lot of disease, where you basically are fine, monitor tumor growth, and usually indolent growth, and the median time to start treatment, it might be around 1.5 years or so. There's some data from Dr. Rini is one example of that assessment. And then you have the other group of patients, also another subset of patients where you think that prognosis or survival is not going to be impacted by kidney cancer. Those might be elderly patients with a lot of comorbidities. They have other problems, and the goal of the game is to control the cancer from progressing and giving problems, but the survival will not be impacted by advanced renal cell carcinoma. And for those individuals, which might be another out of 10 patients, you might see a patient every 10 or so. Sometimes a TKI as monotherapy can be appropriately considered. So there's still a role, in my opinion, for a TKI monotherapy. For everybody else, in general, we tend to favor an IO-based approach, whether it's an IO-IO or it's an IO-TKI. And you have a number of them. You have ipi-nivo, ipilimumab-nivolumab combination as IO-IO, and then you have, axitinib pembrolizumab, lenvatinib pembrolizumab, or cabozantinib nivolumab. All these immunotherapy-based approaches have been shown to improve outcomes, quality of life the same, if not better, depending on the combo we're talking about in their respective studies. And they also improve overall survival. And so they should be considered the gold standard. For patients with good risk, there's still a debate about, some folks still consider a TKI monotherapy. It is true that a lot of the patients with good risk, or a good number of patients with good risk RCC, tend to have an angiogenic signature, meaning they are well treated and their outcomes are good with anything you do, including a TKI monotherapy. But if you're playing the long-term game, thinking about, a patient who you're expecting to live many years, even in those patients, there's a good reason, or there's data to support the use of an IO TKI approach for those individuals. So in general, in my practice, I do consider an IO-based approach for most patients with advanced RCC, with clear cell. In other words, you are using endpoints that we reported in those trials, that include response rate or time to progression, progression-free survival. And so when you look at the numbers, just ballparks, right? About, if you consider ipi-nivo, you're talking about, you're expecting, excuse me, 1 out of 5 patients to progress as best response. You're expecting around 40 or so % of people who have tumor shrinkage of at least a third. You expect double digits, 10% or so, complete responses. You don't see disease anymore while on ipi/nivo. The MPFS is probably around, is close to a year, is around that. And so, you know, that helps you, right? Of course, patients are not numbers, but it helps you to give an idea what to do. So as you can see, you know, most patients will not achieve complete response, right? Now, part of that, you know, 30+% of patients who got partial response, so a subset of them achieve a very deep partial response. In other words, you see disease, but disease is very, very, very small, right? So those deep responses, that includes complete responses and the very significant partial responses, you know, seem to be the patients who do the best, by the way. But you do expect for the vast majority of patients being offered ipi/nivo to progress on therapy, and those are the numbers. For an IO-TKI approach, and I'm just considering the 3 combos have shown a survival advantage, so I'm taking aRCC, avelumab out of this conversation, you are expecting a ballpark of around 50 to 70% response rates. You are expecting, meaning, you know, in that amount of patients, you expect a tumor shrinkage of at least 30%. In addition to that, you expect also double digits as far as complete responses, maybe 10 to 12%. I mean, it will be higher with pembro for the, for the independent review. The investigator review was a little bit closer to around 12% or so. And so again, it's a subset of patients who achieve complete responses. And what I think is also important is the number of patients who achieve progressive disease as best response. In other words, tumor doesn't, the treatment doesn't touch the disease. We're talking between, 10 or so % to about 5 or 6%. So that number is lower. So the number of progressors is lower with an IO-TKI. The number of CRs is about the same. The number of overall partial response plus complete response, it's a little bit higher. 20% may be higher with IO-TKI. Now, that does not mean, we don't know how much response predicts overall survival advantage, or in other words, how much of those responses are durable over time, translating into delaying time to next systemic therapy, and hopefully making, getting those remissions, thinking about cure, right? We don't quite know that. The best data we have is for ipi/nivo as far as follow-up over 5 years. That's the best we've seen thus far. The other treatments will follow. We'll get there. Cabo/nivo just got data, 3.5 years of follow-up, and aRCC is about that, 42 months. So we're getting to know more about what happened to these patients over time. And to your question about what happens as patients get on these treatments, with an IO-TKI, you're expecting median progression-free survival between 1.5 years to 2 years, right? So that's for half of the people. So the other half will do either better or worse, obviously. But the question really is, do we have a subset of patients that remain on this treatment or off treatment without progression? And we now have data also showing that beyond 2 years, we stop the checkpoint and you continue on TKI. We've seen Cabo/nivo, that data for Cabo/nivo. We've seen that data for LAMP-PAM, for example. And those patients tend to do particularly well. Remember, you selected patients who were able to get on IO for 2 years without progressing, and you discontinue the IO and you continue on TKI. So in those situations, those patients seem to be doing quite well. In the LAMP-PAM, for example, we're talking about 30% of the people out of the 300s, about 100 or so. And so it's a subset, the same with Cabo/nivo. So what happens 5 years later, what happens 7 years later, 10 years later, we don't quite know. I'm hopeful that we'll see a plateau of the curve, which basically represents what we can say, or is another way to show what we say in clinic, which is hopefully, listen, if you go on this IO-based approach, there's a 20 or 30% chance of you being without progression, 5 years later, or 3 or 4 or 5, 3, 5, 7, 10 years later, right? That's the goal, and so I think that's probably it's one of the questions we'll be able to answer in the future is understanding these durable remissions. How long is that? How long do you define durable? What is durable to you, and what is durable to a patient? And in the cases when that doesn't happen, which is still the majority of the population, what do we do when they progress?